Hi there, my name's Daniel Campioni-Norman. I'm an FY2 at St Heliers Hospital, and today I'll be talking about obstructive jaundice. Hopefully, by the end of today, you'll be able to differentiate between different types of jaundice, identify the clinical picture of obstructive jaundice, and then differentiate between the different causes of obstructive jaundice. So we'll be covering obstructive jaundice using a case. So we have a 51-year-old male who comes to A&E with jaundice. He's got no past medical history whatsoever, but he has mentioned he's had some weight loss and his skin's been a bit itchy. So just pause the video here and take a minute just to write down at this point what your differentials could be for this 51-year-old male with jaundice, weight loss and itchy sensation. So whenever you're asked a question, the saying for finals is always classify or die, and that's the same for this as well. So you can divide jaundice up into your prehepatic causes, hepatic causes, and posthepatic causes. So if we look at prehepatic causes, this could be things like Gilbert's disease and any hemolytic disease as well. For hepatic causes, so problems of the liver, this can be things like hepatitis, or it could be cirrhosis as well. Then we move on to posthepatic causes. So this is generally obstructive causes such as gallstones in the biliary system or pancreatic cancer. So we've now given our differentials and we said it's a jaundice and it could be prehepatic, hepatic or posthepatic. So again, I just want you to pause the video and just jot down some features clinically and some biochemical features that could enable us to distinguish these three types of jaundice. So first of all, we'll talk about the clinical symptoms and how this can help us differentiate between the different types of jaundice. So first of all, with prehepatic causes, if we think it's because of a hemolytic disease, the patient may be short of breath, they may have fatigue, they may have a lack of pallor, and you may also feel splenomegaly on examination. For hepatic causes, we're mainly looking for risk factors. So this could be a history of alcohol leading to cirrhotic liver disease, they may have known liver disease, and they could have a history of IV drug use, which can increase your risk of transmission of bloodborne diseases such as hepatitis, which can affect the liver. Finally, for posthepatic jaundice, where we're looking at more obstructive causes, they classically have dark urine and pale stools. Often if they have pancreatic cancer, they may complain of systemic features such as weight loss, and if there's gallstones, they may give you a history of a colicky type pain coming in waves, worse after fatty meals. So now we're just going to outline why you actually get dark urine and pale stools in posthepatic obstructive jaundice. So first of all, we're just going to look at this diagram. So 90% of red blood cells are broken down by the reticuloendothelial system, and the remainder are hemolyzed within the circulation. The breakdown products of this process, one of them is heme. Heme is then converted to biliverdin, and this is then converted to unconjugated bilirubin. Unconjugated bilirubin enters the bloodstream bound to albumin, and is then transported to the liver. Within the liver, hepatocytes then conjugate the bilirubin with glucuronic acid and glucuronyltransferase. This conjugated bilirubin is then secreted into the small intestines with bile in micelles. It is then deconjugated to urobilinogen by large intestine bacteria. From here, two things can happen to urobilinogen. It can be further reduced to stercobilinogen and excreted in the feces, giving it its brown colour, or it can be reabsorbed and transported to the kidney, where it's then excreted. If we have an obstructive jaundice, we stop the conjugated bilirubin exiting the liver and entering the small intestine. This means we get no further reduction of the conjugated bilirubin, so we don't get stercobilinogen or urobilinogen. If we don't get the stercobilinogen, we lose that dark colour to the stool, so we get pale stools. If we lose the urobilinogen, which gets excreted in the urine, we lose our urine colour and we get dark urine. So we've talked about how we can clinically differentiate the different types of jaundice, but what about the biochemical picture on the bloods? So classically for this, we'll look at the LFTs. In an obstructive jaundice, you'll get a markedly raised ALP. In a hepatic jaundice, you tend to get a more raised AST and ALT. So now, here are just 2 example questions for you to try to see if you can differentiate between the different types of jaundice using the bloods. So in patient number 1, we have a raised bilirubin, a raised ALP, a particularly raised AST and a particularly raised ALT. Then in number 2, we have a raised bilirubin again, a markedly raised ALP, and a slightly raised AST and ALT. So just take 30 seconds, jot down your answers, and then we'll go on to it. So hopefully you got that number 1 is a hepatic jaundice. We have a raised bilirubin, and if you look at the rest of the LFTs, we have a markedly raised AST and ALT with only a slightly raised ALP. Whereas we look at number 2, which is an obstructive jaundice, and there you have the markedly raised ALP with a slightly raised AST and ALT. So if we go back to our case now, so we had our 51-year-old gentleman who came to A&E because he was jaundiced. We now ask him some more questions. So now you mention it to him, he tells you that he does have some dark stools and pale urine, but he doesn't have any abdominal pain. The bloods come back and he has a significantly raised ALP with a low AST and ALT. So with our dark stools and pale urine and the significantly raised ALP, we can now assume that this is an obstructive jaundice. But he mentioned he had no abdominal pain. So what is the significance of this? The significance of our patient lacking abdominal pain links back to Courvoisier's law. So Courvoisier's law states that in the presence of jaundice, a painless enlarged gallbladder is unlikely to be due to gallstones. If we look at obstructive jaundice, the top 2 causes are gallstones and pancreatic cancer. So in our gentleman who had a painless obstructive jaundice, we can say this is likely due to pancreatic cancer. You would of course go on to get CT imaging, which would confirm this and also allow you to stage the cancer as well. So hopefully by the end of this lecture, you should now be able to identify different types of jaundice using clinical features and the blood picture, and also be able to differentiate between causes of obstructive jaundice. So that's the end of the lecture. I hope you found it useful, and as always, if you have any questions, please feel free to email me.